Welcome to OAC Health Talks. I'm Joe Naglowski, President and CEO of the Obesity Action Coalition, and we are excited for you to join us for this educational series that dives deeper into specific health topics that we know are important to you and the OAC community. Health Talks are designed to empower you while providing straightforward, practical answers and insight from trusted experts. So let's dive into today's topic.
Hello everyone, I am Dr. Nisha Patel, and as I mentioned in my promo video, I'm a board-certified clinical lipidologist, obesity and culinary medicine physician, and I am so excited to be here to talk to you all about this very important topic in the field of obesity medicine is medication treatment, and really trying to understand, what is really truthful and factual information from all of the interesting headlines and information that's floating out on social media and on the news. So we're going to be separating fact from fiction today, and hopefully leaving all of you with information that you can take back to your healthcare providers to talk more about, whether medication treatment is an option for you. So I always like to start off my talks with reminding everyone, whether that be my colleagues, if I'm giving them a talk, or patients, that obesity is a chronic disease. And in the US, the American Medical Association first recognized obesity as a chronic disease in 2013. And it really meets all of the criteria of a chronic disease. So I'm talking about chronic diseases like high blood pressure, diabetes, heart disease. Obesity falls into that category of, being a chronic disease. And the reason I mention this is because there's this narrative in our society and even in aspects of healthcare that obesity is due to a personal or moral failing and that people just don't have enough willpower. But that's not true. We know that there's actual biology and physiology that's in play, and that there's dysregulation of this biology and physiology that contributes to the development of obesity. There's a lot of different causes and contributors, and so it's not fair or even factual to say that obesity is due to a lack of willpower or that it's somebody's fault that they've developed obesity. So I always really want to make sure that I hone this point in, because it's very important, especially when we're talking about treatment options and trying to understand how these different treatment options can help our patients. And so remember, obesity is a chronic disease. If you take nothing else away from this presentation, we really want to put that point in. So let's talk a little bit about treatment. I'm not going to be able to, spend a lot of time talking about obesity as a disease, why obesity develops, but, this goal of this presentation is to talk about medications and really giving you that factual information. But I think it's important to understand that when we talk about the treatment of obesity as a disease, that we're looking at it from a very comprehensive approach. I'm a medical doctor, and when I think about all of the tools that we use to help our patients, it's not just medications or nutrition or physical activity. It's all of these combined that we use in a comprehensive manner to help our patients. And I talked to them about that at the very first visit, that look, we have these buckets or tools that we use and they all work together. And that includes nutrition, like I said, physical activity, behavioral therapy, pharmacotherapy, or where medications fall into line, making sure that patients have healthy sleep habits, making sure that there's stress management techniques that they're involving in their lives if they're experiencing increased stressors. And of course, bariatric surgery, which is not the topic of this conversation today, but it is also a tool to help our patients improve their health outcomes. And speaking of health outcomes, what's the whole point of treating obesity as a disease? We really focus on it from a health standpoint. My goal as an obesity medicine physician is to help my patients live their happiest, healthiest, and longest life. It's so that my patients can do all of the activities that they enjoy, whether that be chasing after their grandchildren or being able to do certain activities that they may not be able to do previously. It's really trying to improve their quality of life and improve their health. And so that's the way I look at it. And I think a lot of evidence-based obesity medicine physicians and other providers look at it that way too. This is different again from the messaging that you see in social media or in society, where it kind of really becomes strictly weight focused. And yes, we know that treatment of obesity, a byproduct of treating the underlying obesity, is weight loss, but that's not the only thing that we focus on. We're not trying to make a number on the scale look perfect. We're not trying to, tell people they must be in a certain body shape or size. We really want to improve their health outcomes and quality of life. And we use all of those tools that I just talked about previously to do that. So when we talk about medications, who is currently a candidate for medications to treat obesity? So the FDA does set some guidelines, and the reason it's important to go over this, I want people to understand that these are the guidelines that insurance companies use when it comes to trying to approve or not approve medications to treat obesity. So any patient with obesity, it's BMI-based criteria. Like I said, it's the FDA's criteria. This is what the insurance company uses. This is not like what your doctor made up or whatnot. But patients with obesity that have a BMI greater than or equal to 30 qualifies for treatment with anti-obesity medications. And then patients who fall in the who have overweight or pre-obesity is a BMI of 27 or greater with the presence of what we call adiposity. Adiposity is a medical term for excess body fat. So a complication that's associated intimately with obesity, like type 2 diabetes, heart disease, high blood pressure, fatty liver disease, obstructive sleep apnea. So they have to have one or more of these comorbidities if they don't meet that 30 and above criteria. And then there's, of course, different contraindications to these medications. Contraindications meaning that the medications are not suitable or safe for the patients. And so we want to make sure that we abide by those contraindications and really get that thorough history and physical exam from our patients so that we can help choose the safest medication that is right for them. So you've probably seen headlines on all of the newer anti-obesity medications. So Ozempic, of course, that word is like such a buzzword right now, right? In social media and on the news. And it's important to understand that Ozempic is just a brand name for a medication called semaglutide. And semaglutide is actually, and I'm going to go into this a little bit later when I talk about meds, but semaglutide is actually approved under two different brand names, Ozempic and Wegovy, which seem to kind of be like some of the more popular names that you're hearing about. But what I want to emphasize is that obesity medicine physicians have been treating obesity as a disease well before these medications became available or approved for use in patients. There have been medications that have been approved as early as the 1950s that we still use to this day to help our patients with the treatment of their obesity. And one of the medications is phentermine. This is a medication that we commonly use. It's a much cheaper alternative compared to some of the other newer medications out there. I prescribe it in conjunction with other medications as a part of like multimodal pharmacotherapy. And so it's, again, really important to understand that the semaglutide under Ozempic and Wegovy, for instance, are not the only medications that we use for the treatment of obesity. There's, combination medications that we use, like phentermine topiramate. Qsymia is a medication. It's an oral medication. There's Contrave. And semaglutide actually wasn't our first GLP-1 medication that was approved for the treatment of obesity. We actually have liraglutide or Saxenda. And so, again, just going back to the point that I'm trying to make is that these medications that you're hearing about in the news are not the only medications that we use. We use medications off-label. We really look at our patients' medical history and understand like what they'd be a good candidate for, what can they afford, what can they reasonably take for long term. And all of those factors go into our decision making on our recommendations and really trying to help our patients understand this and so that they can also make the best decisions for themselves. And I won't be able to talk specifically about each and every medication here, but I do want to jump into some common myths and misconceptions about medications to treat obesity. So let's dive in. So again, you've seen the headlines. They're everywhere. I mean, I see a new one like almost every day, and it's like very cringe, as an obesity medicine physician. You're just like, how have we turned this treatment of chronic disease into this kind of Hollywood sensation, really kind of focusing just on the vanity aspects of it when we're really trying, again, help patients improve their quality of life and their health outcomes. But there's no shortage of these headlines. And so I really, really encourage you, when you see headlines like this, it's very easy to get into this habit of like, headlines are meant there to be like clickbait. You want to like just read the headline and be like, oh my gosh, like, Wegovy causes X, Y, and Z, or like this medication does this. And did you hear about this particular celebrity that had a bad outcome or whatnot? It's important to take a step back and realize you're getting a very like one-sided view, a narrow view when you're seeing these headlines. And I hate to say it, but some of them are not very scientifically sound when I'm reading them. And so again, very important to put your skeptical hat on and be like, does this really make sense? Does this situation potentially apply to me? Taking some of these headlines with a grain of salt, I think is really, really important. And talking to your healthcare provider, if you have questions about what you've read in the news, I think is very, very important. I spend a lot of time dispelling myths in my patients, and I think it's important. It's important to have those science-based conversations. So, number one, why are we using a diabetes drug for weight loss? And I think this needs a little bit of explanation to really kind of understand. So, when we're talking about this particular myth or misconception, I'm talking specifically about the medication Ozempic. So, like I mentioned earlier, the medication semaglutide is currently approved under two different brand names in the United States, under Ozempic and Wegovy. It was first approved in 2017 under the brand name Ozempic for the treatment of diabetes. But what we know is that diabetes and obesity are very intimately linked. Obesity raises the risk of developing type 2 diabetes. And so when we treat the underlying obesity, we also can help improve the diabetes. And so even though Ozempic technically is a medication that is marketed as a diabetes medication, we know that in clinical trials it did lead to clinically meaningful weight reduction, which also helped with improvement of diabetes in addition to other aspects of the GLP-1 mechanism of action. And so that medication, semaglutide, ended up going through its own round of clinical trials, specifically for the treatment of obesity, and was approved under the brand name Wegovy in 2021 by the same pharmaceutical company. And what unfortunately happened is that there was supply shortages and an increased demand for the medication Wegovy, and this led to basically just scarcity of even finding the medication. And so if you think back, well, if we can't find Wegovy, that's semaglutide, well, we have Ozempic, which is also semaglutide, same medication, and it was being prescribed off-label, even though it's the same drug under two different brand names because there was a shortage of Wegovy. And so this really led to this misconception in the news and social media that we were using a diabetes drug and taking it away from people that needed it for their diabetes and using it for the treatment of obesity, when in reality, again, these conditions are very intimately linked. It's the same medication under two different brand names. And so it isn't really factual to say that it's solely a diabetes drug. It's just marketed as a diabetes drug. It's a matter of marketing and brand name. And so again, it's important to, if you see headlines about diabetes drug being used for weight loss, is what they usually say. I say treatment of obesity as obesity medicine physician. It's the same medication. It's just there were supply shortages that led to off-label prescribing of Ozempic. Now we're starting to see improvements in the Wegovy supply chain. And so, hopefully that, won't be an issue, but who knows? It's kind of up in the air right now. There's been some new chatter that there might be further supply shortages of Wegovy at the lower doses, but we'll have to see what really pans out. So important to remember, same medication, two different brand names. Diabetes and obesity are intimately linked. We don't want to create more stigma towards patients with obesity by saying, oh, it's a diabetes drug. Why are we using it for the treatment of obesity? Misconception number two isn't taking medications to treat obesity the easy way out? Well, I'm here to tell you that many, many of my patients, when they come to see me, they have tried a number of different interventions to improve their obesity. They have spent thousands of dollars on different programs, different things that have been marketed to them, and it is not the easy way out. Again, obesity is a chronic disease. Your body actually fighting weight loss by creating certain processes that make it harder to lose weight and even harder to maintain that weight loss. And that's not something that you can overcome with willpower alone. The way I think about medications is that it really helps level the playing field for our patients so that they can use the medications to make it easier to follow lifestyle changes, because they're not constantly fighting their biology, that hunger, those cravings, that food-seeking behavior, that lack of satiety that some of my patients are experiencing. And so really, again, levels the playing field and helps fight that neurohormonal dysregulation to help our patients achieve and improve their health outcomes. So no, taking medications is not taking medications to treat obesity is not the easy way out. Many of my patients have tried so many different interventions, and it's not fair to say that it's the easy way out. We don't actually say that about medications to treat heart disease, do we? Or high blood pressure, or even diabetes, right? Those are all chronic diseases too. We don't tell people that if they're taking a blood pressure medication that it's the easy way out. But unfortunately, again, the stigma runs deep in society and in aspects of healthcare, and so for some reason, taking medications for obesity is seen as the easy way out, when in reality, it's not. So misconception number 3, if I stop the medication, won't I regain the weight? What is the point of starting it in the first place? I think this goes back again to the point that obesity is a chronic disease. The medications that we prescribe for the treatment of obesity, they're not meant to be prescribed in the short term. We're not trying to prescribe them for 3 or 6 months. If a patient gets to a healthy weight, again, we have to be able to help them maintain that weight in the long term. And the medications are a tool to do that. So yes, it is true that if you abruptly stop a medication, and we see this in clinical trials, that patients can have a weight rebound to the baseline, kind of near the baseline that they were before they started the trial or medication. But if it's a chronic disease, we really can't see it like that. We can't see it like, we're just going to use the medication for a finite period of time and then just stop it. We need to be able to really grasp the concept that obesity is a chronic disease, and the medications are meant to be prescribed in the long term. And again, it's about improving health outcomes. So, when it comes to what is the point of starting it in the first place, well, we want to use all the tools that are available to us to help improve your health, right? And that includes nutrition, physical activity, sleep, optimizing sleep, stress management, behavior therapy, medications, and bariatric surgery. And so it's a multimodal, comprehensive approach, and medications are a part of that approach. And so we wouldn't, again, say to somebody that needs, they had a stent placed for heart disease, we wouldn't say, well, why are you taking that blood thinner for the rest of your life? We wouldn't say that to them. So why are we, again, saying it to patients with obesity that, you're going to have to take that for the rest of your life? Do you know if you stop that medication, you're going to have weight regain? Yes, that is a possibility. But the whole point is we're not trying to stop that medication abruptly. So number 4, are compounded versions of semaglutide a good alternative if my insurance doesn't cover Wegovy or Ozempic? Well, that's a good question. And my answer is no. And the reason is that compounded versions of the medication semaglutide are not FDA approved. I don't quite understand how compounding pharmacies are doing this or trying to compound semaglutide, because the medication is under patent, meaning the pharmaceutical company, as far as the composition and how the medication is made, that process, it's not privy to the public eye. And so first off, I always question how do they know that they're actually making semaglutide? And number 2 is that these medications are often compounded with other substances or medications. And so, and again, you don't really know what those are. You kind of have to go based on what they're telling, what the compounding pharmacy is telling you, or whoever is marketing it to you is telling you. And I'm just not willing to take that kind of risk in my patients. I can't attest to the safety and efficacy of compounded medication, compounded semaglutide, I should say. And so for that reason, I do not prescribe or promote any compounded semaglutide. And states are starting to really crack down on pharmacies that are, making compounded semaglutide, or clinics that are selling it. And so again, it's important to understand that this is not the FDA approved version of semaglutide, which is either Ozempic or Wegovy. It's not really clear how it's being made. There's been some concerns in the past about safety and sanitation standards in compounding pharmacies. There's been some outbreaks of diseases with other compounded medications in the past. And so again, it's not worth the risk to me, even though they are often marketed and sold at a cheaper rate than what, typically the cash prices for Wegovy or Ozempic. But I personally do not recommend it. The Obesity Medicine Association has a statement basically not recommending compounded versions of semaglutide. I think it's a really great statement that's out there and available for people to read. And then number 5, can I eat anything I want while taking medications to treat obesity? And the reason I put this one in here is because I've actually seen some ads out there where, there's individuals or hired actors that are basically kind of promoting the medications as a way to eat whatever you want. And they're doing it kind of as a quick fix, like I can eat all the candy I want when I take this medication. And I want to kind of go back to the comprehensive treatment approach that we're talking about with obesity. Remember, nutrition is actually a very big component of it. And even though the medications are there to level the playing field and hopefully make the healthy habits easier to continue and form, it's not like a free-for-all for us to kind of neglect those aspects of our lifestyle. That's the foundation of care. And so, the messaging that I see on social media or certain commercials from some of these companies about, being able to eat whatever you want, it kind of goes against what we consider as comprehensive obesity care. So even though the medications are there as a tool, it's still important for you to eat a health promoting dietary pattern. Now that's going to look different for everyone. There is no one size fits all nutrition pattern for treatment of obesity. It really, there's a lot of different factors, and I could talk, this is a whole lecture on its own, but there's a lot of factors that go into what ultimately ends up on our plate, whether that be societal influences, our budget, there's, food preferences, cultures, so many different factors. And so again, this is going to look different for everyone, but we really want to stick with the basics of what we know is a health promoting dietary pattern. And, trying to incorporate fruits and vegetables and legumes, nuts, seeds, lean proteins. I'm trying to really make that the foundation of what we're eating, knowing that it's going to look different for everyone and knowing that we're not trying to make this an overly restrictive dietary pattern. I don't believe in an all or none or black and white thinking when it comes to food, because I think that can actually be detrimental at the end of the day. I find that sometimes when my patients, quote unquote, cut out all of their cut out foods that they enjoyed previously, maybe to more of a degree, that if they cut it out completely, it's just like they want it more, they really want to be around it more, or they feel guilty if they encounter that food later and happen to have some of it, and it's just kind of creates this vicious cycle. And so I don't like the overly restrictive pattern of eating. And a lot of that, unfortunately, is messaging that we see on social media from diet culture. And so really trying to make the foundation as many health promoting foods as possible, but understanding that we eat for a lot of different reasons and kind of allowing some room to incorporate some of the other foods that we may be trying to eat less of. So it's important to remember that medications are a tool, but we still want to have that health promoting dietary pattern. And that's regardless of, whether we're treating obesity or heart disease or diabetes or high blood pressure, for or fatty liver disease, for all of these types of diseases, these cardiometabolic diseases, nutrition is the foundation, and lifestyle changes is the foundation of care, and knowing that the medications are a tool. So very, very important to remember. And I also want to mention that something that is so interesting and actually just so rewarding for me to see, and also for what my patients are feeling, is that the medications can actually help make, eating healthier easier. I see that, I see it in my patients when they come back to their follow-up visit when I've started a medication and they've said, doc, I just don't have this intense hunger that I used to have, where I would eat, but then I would get hungry within the hour. And it was, something that their biology, their own genetics was driving, right? That was their own type of hunger physiology that they were experiencing. And it was really, really bothersome to them because they knew that they just ate. They felt like they ate enough, but they were hungry much quicker than maybe a family member or a friend. And so the medication really helped, again, level the playing field in that aspect. I've had patients tell me that, at work, they would pack their lunch prior to medications, but then if a coworker brought food in that they were trying to eat less of, or if there was like a potluck at work, it would just be very difficult for them to kind of maintain that healthy eating pattern. Despite them bringing their own food, they'd still really, really crave these foods really strongly that their coworker or somebody else brought in. But the medication actually is helping them. They might have some of that food, but not as much as before, and they're feeling satisfied at that point, and they don't feel guilty about eating it. And so it's so beautiful kind of seeing this the struggle improving in my patients, and they feel it too, and they're just like, I'm so happy that I'm not constantly fighting these they don't call it neurohormonal dysregulation, I do, but they're constantly not having to fight their own biology when it comes to their obesity. So if I'm interested in starting a medication for the treatment of obesity, who should I talk to and what questions should I ask my provider? And this is an excellent question. I get a lot of questions from some of my followers on social media. How do I find an obesity medicine doctor? How do I go about, really trying to have these conversations with my physician or provider? And I will say that, in the US, there's only 7,700 obesity medicine physicians, and I wish there were more, but in reality, that's just the reality of it. But if you are able to find an obesity medicine doctor by going to you can go to the American Board of Obesity Medicine. There's a place there you could search for, providers that are in your area, and just trying to see if they're, if they have clinics or practices that you could be seen, to be seen. And I definitely have had people come to me and be like, will you be my doctor? And of course I say yes. But hopefully you can find somebody that is in your area, or even via telehealth, that you can start having these conversations with, or really getting this factual and scientific information. That's not to say that there are not other physicians or providers that aren't capable of taking care of patients with obesity. We really need all hands on deck. And if, there's primary care providers that are doing it. There's different specialties that are really trying to incorporate obesity management into their practices. But if you are able to find an obesity medicine physician or a provider, I think that would be the first step to start, or having a conversation with your primary care provider, whoever that might be, and saying look, is there someone that you could refer me to? I'd really like to really talk about how to treat my obesity. So first, to try to identify that individual. And then really, when I have a patient that comes to me, I spend a lot of time first learning about their medical history and really trying to understand, what their journey has been like. How have they gotten to the point that they're now seeing me? And what are their goals? What is it that's important to them? And then really looking at it together from a health standpoint, also what are other, what else do we need to try to improve on? And so, when taking all of that information into consideration, that's when I look at our armamentarium of medications, and I think, okay, well, what is a good option for you based on, what your goals are, what your health history is, because I think that's very important. There are some medications that we can't use in specific medical conditions, and they may not be the safest option. And so really trying to understand what the options are. And I have a handout that I use, and I usually circle what I think is going to be the best options for them. And then really giving them some time to think about, okay, so Dr. Patel and I talked about these options, what, go home and think about well, what really fits with my lifestyle? Do I really want to take a medication every day? Or, can we try to get a medication that's a once a week injectable because that fits with my lifestyle better? Now, I will say some of this comes down to insurance coverage, and it's not anything that you can control or I can control. It's really just the unfortunate truth. And so sometimes insurance coverage does dictate kind of what medications patients can be on. And, really trying to find the most affordable option for them, I think, is really important. And this is why we use some of those medications off label, because they tend to be cheaper. But just knowing all the options, talking through them with your healthcare provider, understanding, what potential side effects are, what to look out for when you're taking medications, and how to really, like the one thing I do talk to my patients about, of course, are the side effects, and then how to contact me or how to get a hold of me whenever, if they're experiencing, adverse effects or side effects from the medication, because I think that's really important. So when you're out there talking to a healthcare provider, making sure that they understand your history, they understand which medications are the best option for you, and then really having a plan, like if this medication is covered by my insurance, then what is the other options for me? And if I'm having trouble with this medication, like let's say I'm having side effects, like what's going to be the plan of action? Because then, whenever I do have patients that message me saying, well, I think the medication's causing this, or I'm having some nausea, we kind of troubleshoot and work through those symptoms and try to get our patients past that, especially when you're up titrating some of the injectable medications. We tend to see the nausea like in the beginning and when we're up titrating the medication. And this is why we, start low and go slow. I always tell my patients that. And so, being in the hands of an experienced provider is important. And I think a personalized approach is very, very important. We're all, we all have different genetics. We have different biology, and, prescribing like a one size fits all, or saying like, this is the only medication that I hand out and you can go on your merry way and I'll see you in 6 months it's not the right approach. This does require lifelong comprehensive care. And so you want to ask your, healthcare provider, like how long or when is going to be my follow-up visit? How often am I seeing you? Am I also seeing a health coach or a dietitian, or who else is involved in this care? Those are very, very important questions to ask. But I think going back, trying to find an evidence-based provider, and then also really talking through the different options of medications and talking through all of the options of medications for that matter with them, and coming up with the best plan for you is the most important thing. So key takeaways, like I said, medications are a part of the tools that we use for the treatment of obesity, but they're not the only tool. Again, it's a comprehensive approach. And it's in addition to working on those healthy lifestyle factors. And so we want to make sure that we continue to emphasize that, or whoever you're seeing is also emphasizing that. And we don't want to, market medications as a quick fix. And then medications are meant to be prescribed for the long term, like any other chronic disease. Again, this is not like a 3 or 6 month journey, right? It's a chronic disease. We want to help you improve your health outcomes for the rest of your life. So I always tell my patients, whatever you're doing now, we want to make sure you can do it for the rest of your life. It's not something that, we're talking about like a decade, 20 years down the line. It has to be a sustainable approach, and it has to be a personalized approach. All right. I think that's all I got. This was really great, and I hope you all enjoyed it. See you later.
The OAC has a variety of educational opportunities for you throughout the year, but one of the best places you can turn to for quality, unbiased education is our resource library. Simply visit obesityaction.org/library to check out our brochures, articles, guides, videos, and more health talks. Also be sure to subscribe to our YouTube channel to get notified about any future educational events. Thanks for joining us.